afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Improving Adult Immunizations in Maryland call. All lines have been placed on listen-only mode, and the floor will be open for your questions following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Elena Bauer. Elena, the floor is yours.
Thank you. Welcome to VHQ's first educational webinar focused on adult immunization. Quickly, I would like to go over the agenda. First, we will have a personal testimonial from Bernard Halbert, a Medicare beneficiary, who will tell us about his experience with shingles. Next, we will be presenting information about the 2015 adult immunization recommendations by Dr. David Kim. Immunizations are not a shot in the dark. After the presentation, there will be time for Q&A. If you would like to have a copy of the presentation, it has been placed on our online community. If you can sign in today and access the presentation. There are also other tools and resources to assist you with improving immunization. One tool I would like to highlight is the Patient Assessment Tool, or QUIZ. This tool can be used by providers and beneficiaries to determine what immunizations they may need. It is a great tool that can be placed on patient portals. At last, information about adult immunization and how this relates to meaningful use in cardiac health. So let us begin. A quick introduction to VHQC for those of you who are unfamiliar with our organization. VHQC is the Quality and Innovation Network Quality Improvement Organization for Maryland and Virginia. VHQC convenes patients, providers, and stakeholders to provide improved health quality and achieve better health, better care, and at lower costs. We do this work through the CMS QIO program, the cornerstone of Medicare's efforts to improve the quality and value of health care from its more than 45 million beneficiaries. Hi, my name is Elena Bauer, and I am the Improvement Consultant at VHQC. I support the Adult Immunization Task, which is focused on improving immunizations by improving documentation, assessment, and reporting. So without further delay, we move to our first presentation. I would like to introduce Bernard Halbert, who has agreed to share his personal stories of shingles today. Bernard is a Medicare beneficiary, and he lives a very active life. He still works part-time for a private Christian school. He's an active member of his church, an active community volunteer, and he enjoys vegetable gardening and going to auctions. And he still practices as a carpenter, which is his lifelong profession. Hello, Bernard.
Hello, how are you today?
I'm good. Thank you for joining us and sharing your story. First of all, can you tell us what it was like to have shingles?
It was terrible. I had chickenpox when I was a kid, and about 5 years ago I got the shingles, and they started in the lower part of my back, came all the way up my side, and down to my belly button. And the pain was terrible. And it was even real uncomfortable to wear clothing. The doctor gave me prednisone to treat them, and that upset my stomach, and it was just about as bad as the shingles. So, but I continued my daily routine, but at times it was miserable, especially in hot weather.
Wow, it sounds like it was very painful. Did your physician recommend that you get the herpes zoster before getting shingles?
No, not at all. In fact, I never even thought about having them.
And then after you had the shingles, did your physician recommend that you get the vaccine?
He did. Yes, he did. And I did get it.
Great. What do you wish you had known before getting the shingles?
Well, I wish I would, knew that there was some way maybe to prevent them and maybe make it a little more comfortable. They tell me that the shot don't actually keep you from getting them, but that it makes it more viable when you do get them, It helps if you do get them, they're not as bad.
Right. So what would you tell physicians, families, and friends about shingles?
I'd recommend to everybody, I always tell everybody that I see that to get the shot. I said, I want to speak on my worst enemy.
Thank you, Bernard, for sharing your story. I was unaware of the lasting effects of shingles, the fact that you still have pain now, even after you've had the vaccine from having shingles. So thank you very much for answering those questions.
You're welcome.
Does anybody else, thank you. Does anybody else have any questions for Bernard? Thank you again. Briefly, I would like to use some data to show how well we're doing with immunizations for herpes zoster. The current rate that we have right now is 20%. So nationally, 20% of patients are receiving the herpes zoster vaccine. Our goal of improvement is to reach 30%. I've also included some data about influenza and pneumococcal vaccination. Influenza, our national rate is 42%, and our goal is 70%. So huge improvement that we want to improve there. And pneumococcal, the current rate is 60%, with the goal of improvement to 90%. For Maryland, we don't have any immunization data for herpes zoster, and part of that reason is that we're not collecting that data through Immunet. We want to improve Immunet registration, and that is a way for us to collect data to see how well we're immunizing beneficiaries. So moving on. So the way to improve our rates is to do education. And so that is what we decided to do our first presentation on, was to actually do education about the recommendations for immunization. Our presentation today is by Dr. David Kim. He is the captain of U.S. Public Health Service, Immunization Service Division of the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention. He will provide educational information about what immunizations are recommended. Dr. Kim has been with the CDC since 1995, and he joined the Immunization Services Division in 2014. Among other duties, he leads the Advisory Committee on Immunization Practices, Adult Immunizations Working Group, and presides over the adult immunization schedule in the United States. Prior to his work on adult immunizations, Dr. Kim worked on HIV drug resistance surveillance, public health emergency preparedness, managing quarantine stations, refugee health, and cruise ship epidemiology. He is a graduate of the University of Colorado School of Medicine, and he received his training in internal medicine at the University of Rochester in Rochester, New York. Thank you, Dr. Kim, for joining us today and sharing your expertise on adult immunization. Please begin when you are ready.
Well, thank you very much, Elena. It was a very kind introduction, and I really do appreciate your kind invitation for me to speak at this webinar. Let's see if we can get to the first slide.
Okay, thank you.
Okay, well, good morning and good afternoon, everyone. Thank you so much for joining us on this webinar. And it's truly a privilege for me to be here and to talk about adult immunizations and how to promote adult immunizations. At CDC and at state health departments, immunization programs are typically divided, at least conceptually, if not by staff orientation, into child, adolescent, and adult programs. As you're undoubtedly aware, adult immunization has traditionally not enjoyed the same high priority and physical and legislative support that childhood immunization enjoyed. However, by the end of this discussion, I hope you will remember that working in adult immunization is not like taking a shot in the dark. Indeed, implementing adult immunization programs, when systematically applied and with evidence-based strategies, improve the health of our patients and of course, their families and coworkers. And in the end, it'll help with our community. and your role in improving adult immunization coverage rates as healthcare providers and administrators simply cannot be overemphasized. First, a necessary disclaimer and a disclosure that for anything I say that's considered stupid, that would be entirely my fault, and that I don't have any conflict of interest to disclose to you. There seems to be a little lag in me advancing the slide, so if you would just be patient as I transition from slide to slide. The content of this discussion is as follows. I will start with the burden of vaccine-preventable diseases among adults in the United States, and that will be followed by vaccine coverage rates for adults, and I will touch on some racial and ethnic disparities. Then I will show you the 2015 adult immunization schedule, which I'm sure most of you have seen, and give you an update from the ACIP meetings that took place since the schedule came out in February 2015. I'll give you a quick primer on how the ACIP functions so that you get a sense of how ACIP recommendations come about. And then I will close by sharing with you the adult immunization practice standards that was published in 2014 and some strategies to improve adult immunization. The burden of illness due to diseases for which vaccines are available is quite high. Many of the infections preventable through vaccination are also very common among adults in the U.S. In fact, the vast majority of vaccine-preventable diseases in the U.S. occur among adults. Most causes of vaccine-preventable illnesses among children are relatively uncommon due to high rates of vaccination and very effective vaccines. For influenza, the burden of illness varies from year to year. There are millions and millions of cases and an average of 226,000 hospitalizations that occur each year. More than 75% of those occur among adults. Of the 3,000 to almost 50,000 deaths occurring annually from influenza, over 90% of those actually occur among adults. Invasive pneumococcal disease, also known as IPD, is common among adults. And there are estimated 35,000 total cases and 3,500 deaths in 2013, the most recent year for which we have complete data from IPD. Most of the IPD cases and nearly all of the IP deaths occurred among adults. The U.S. has seen an increase in pertussis, also known as whooping cough, in the past several years. And among a total of over 40,000 total recorded cases in 2012, about 9,000 of those occurred among adults. Hepatitis B. Hep B continues to occur with over 3,000 acute cases being reported in 2010, which actually translated into an estimated 35,000 cases for the country, with more than 90% of those cases occurring among adults. Zoster, or shingles, that you heard Mr. Colbert talk about a little earlier, is also common. About 1 million cases of zoster occur annually in the U.S., with the risk of dead and herpes zoster increasing as adults get older. Putting that disease burden into economic terms, here's what we see for influenza. Each year, the direct cost for medical care for influenza in the U.S. is estimated to be over $10 billion. Adding on to that, the cost associated with the loss of work or loss of life yields a staggering estimate of $87 billion. Now, what about the flu vaccine? Notwithstanding the influenza strain drift that significantly lowered vaccine effectiveness in the past flu season, the latest available data from the 2013-2014 flu season, during which 41% of the population was thought to have been vaccinated, suggests that an estimated 7.2 million illnesses, 3.2 million of which needing medical attention, and 90,000 hospitalizations were prevented by vaccination. So clearly, vaccine is good. Obviously, vaccines save lives, and as the previous slide showed, money. So are adults actually taking advantage of these vaccines that are available? For the influenza vaccine, we've seen incremental changes overall for adults over the past several years. While the highest coverage rate was seen among older adults, it remained stagnant at around 65%. Over the past several years, tetanus and pneumococcal vaccination coverage rates for adults has not changed all that much. The pneumococcal vaccination rate for adults 65 and older remained at around 60% from 2010 through 2013, well below the Healthy People 2020 target of 90%. The pneumococcal vaccination rate for adults 19 to 64 with high-risk health conditions also remains stagnant at about 20%, also well below the Healthy People 2020 target. But on a positive note, the vaccination rate for Zoster, as Elena actually mentioned earlier, for adults 60 and older, while still below the Healthy People 2020 target of 30%, has made year-over-year improvements over the past several years. HPV, human papillomavirus vaccine coverage rates for young adults are disappointing to say the least. For young women, the coverage rate hovers around 35%. For young men, even with the surge we saw in 2013, the coverage rate is barely at 6%. Clearly, there's a lot of work to do with our younger population. Now, let's look at the immunization rates for healthcare workers, a population that you're all familiar with. Immunizing healthcare workers, in theory, should really be an easy sell. But you know better, and I know better, given our experience trying to get the flu vaccine into healthcare workers. For Tdap, healthcare workers do much better than the general population. But at less than 40% coverage, we really shouldn't be patting ourselves on the back. Healthcare workers do a better job of getting the hepatitis B vaccine compared to Tdap, but at around 60 to 65% to prevent an occupational health threat, there remains a lot of room for improvement. The Healthy People 2020 target for hepatitis B vaccination for healthcare workers is 90%. What's more, we have to do a better job of protecting our patients who are at high risk for hepatitis B, such as patients with diabetes who have less than 30% coverage rate for this preventable disease. This is a very busy table, but the point I'm trying to make here is that we continue to see racial and ethnic disparities in adult immunizations. Consistent with the theme from 2012, racial and ethnic difference persisted for pneumococcal, tetanus, hepatitis A, hepatitis B, and HPV vaccines in 2013. And the difference actually widened for Tdap and Zoster. Blacks, Hispanics, and Asians had lower vaccination coverage rates than white, as represented by the bold red negative numbers on this table. For all routinely recommended vaccines for adults, except in a few instances, those numbers represent statistical significance, and in only 2 instances do we see racial and ethnic disparities have better. It's actually less for minority populations compared to whites, and that is hepatitis A and hepatitis B for 19 to 49-year-old patients. And even towards the bottom of the table, we see that even among healthcare workers, we see disparities along racial and ethnic lines. You see that TDAP or blacks or Hispanic healthcare personnel lagging behind whites, and Hispanic healthcare workers trailing whites for hepatitis B vaccine coverage. So why are adult immunization rates so low? That's a million-dollar question, isn't it? There are many reasons, and Elena pointed some of those out. There are many reasons, but four of them actually stand out based on our research. One, adults are simply not aware that there are vaccines recommended for them. Two, their healthcare providers are too busy and have many competing priorities to address adult vaccination adequately. And I'm sure that you're all well aware of this. Three, not all healthcare providers stock and administer all the recommended vaccines for adults. And lastly, four, adults frequently see multiple providers, and therefore vaccination record keeping is disparate and difficult. And Elena mentioned this as well. We're going to come back to this slide later in the presentation. The adult immunization schedule is published once a year. It summarizes the ACIP policies and changes in the preceding year, and is published in the CDC Morbidity and Mortality Weekly Report, also known as MMWR, and the Annals of Internal Medicine. While the content of the adult immunization schedule are recommendations, it carries with it quite the clout, since the vaccines included in the schedule are mandated to be covered by insurers with no copay within a year after the recommendations are published in the MMWR. The 2015 adult immunization schedule was also approved by the American College of Physicians, American Academy of Family Physicians, American College of Obstetricians and Gynecologists, and the American College of Nurse Midwives. This figure summarizes the ACIP recommendations for adults by vaccine along the left-hand column, and age across the top. Yellow bars mean recommended, and purple bars mean recommended if there's a risk or indication present, such as medical conditions or occupation. White bar or white space means that there is no recommendation. And I'm sure that you've seen this figure in various providers' offices who care for adults. This figure is an accompanying figure to the previous figure, and it describes the ACIP recommendations for adults by vaccine along the left-hand column, and medical and other indications across the top. Again, yellow bars mean recommended, and purple bars mean recommended if there is a risk or indication present. White bar space, as I mentioned, means that there is no recommendation for or against the vaccine. Red bars mean contraindicated. It should be noted that these figures, both of these figures, were designed to be read with accompanying footnotes. The 2015 adult immunization schedule did not have many changes from the 2014 schedule. The changes included the recommendation to administer 13-valent pneumococcal conjugate vaccine, shortened as PCV13, in series with a 23-valent pneumococcal polysaccharide vaccine, shortened as PPSV23, for all adults 65 and older. Also changed were the reclassification of the statement influenza antiviral use within the last 48 hours from a precaution to a contraindication, and asthma and other health conditions and from contraindications to precautions for for live attenuated influenza vaccine. And following the FDA approval to expand the age for the use of recombinant influenza vaccine, or RIV, the ACIP changed the approved age group for RIV from 18 to 49 years to 18 and older. But those of you who work with your adult patients to ensure that they're up to date on immunizations know that simple changes really don't mean simple changes. For example, the recommendation to add PCV13 to adults 65 and older seems fairly straightforward. But you know how complex the pneumococcal vaccination recommendations are already. So we knew that adding another recommendation to pneumococcal vaccination was going to add even more complexity to the pneumococcal vaccination schedule. This is the Annals article that was published in February 2015. So in it, we took great care to try to simplify the pneumococcal vaccination schedule. In the article, we focused on the patient presentation and attempted to streamline the pneumococcal vaccination schedule based on vaccine sequence, intervals, and frequencies. So this is more of a patient-oriented menu to decide which pneumococcal vaccine to give to whom and when. This figure was also included in the Annals article. It is a flow diagram to help the busy healthcare provider determine which pneumococcal vaccine to use and for different patient populations. Of course, there's a lot of caveats to the new recommendations for adults age 65 and older to get PCV13. And that's why it's important for the healthcare providers to review the footnotes that accompany the adult immunization schedule when they review the schedule. Now, for 2016, we're anticipating additional changes to the adult immunization schedule based on the discussions and decisions, meaning recommendations, that have been made during the ACIP meetings in February and also in June 2015. The ACIP continues to have discussions on pneumococcal vaccination recommendations and exploring how to make the pneumococcal vaccination schedule simpler. So that has been a task, and it's been a difficult challenge given the complexity already of the pneumococcal vaccination schedule. Pneumococcal vaccination continues to be a topic that is emotionally charged. The most recent ACIP recommendation allows for permissive use of serogroup B pneumococcal vaccines, or MenB, for adolescents and young adults 16 to 23 years of age. Influenza vaccine discussion revolved around the reiteration of a recommendation that was previously made, and that is that all persons 16 months of age and older receive age-appropriate influenza vaccine. Continuing on HPV, ACIP discussions and recommendations revolved around the transition from the 4-valent HPV to the 9-valent HPV. It's comforting to know that the dosing schedule remained unchanged. You will note that the use of HPV vaccine for 13 to 21 years of age is off-label. That is, the vaccine package insert for appropriate use as per FDA licensure does not include its use for males 15 and older. So there's a little contradiction there. There are other instances where the ACIP recommendation is not consistent with FDA licensure, like the use of Tdap, Tetanus, Diphtheria, and acellular pertussis vaccine for pregnant women. The FDA licensure for the two Tdap products that are currently in the market state that the vaccine is for one-time use for pregnant women. However, the ACIP recommendation is that the Tdap vaccine should be administered at every pregnancy, preferably in the third trimester, so as to render protection against pertussis for the mom and the infant. For FDA licensure, vaccine manufacturers need to demonstrate that the vaccine is effective and safe. ACIP recommendations also take into consideration not only the conditions that led to the vaccine's licensure, but also subsequent and ongoing studies on the vaccine's effectiveness and safety. It also includes epidemiologic studies, cost-effective analyses, and public health programmatic considerations. So the two processes, the FDA licensure and the ACIP recommendations, serve very different purposes and may result in ACIP recommendations that are off-label. So to wrap up the 2015 ACIP discussions related to adult immunization, the yellow fever vaccine booster was reiterated to be appropriate for select populations, select travelers, at risk for the disease every 10 years, and that laboratorians who work with the vaccine or with the yellow fever disease in the microbiology labs, that they should get titers measured every 10 years and determine whether a booster is indicated or not. This is in response to the World Health Organization's decision to continue requiring yellow fever vaccination for entry for travelers arriving in select disease-endemic countries in its revised international health regulations. So there's a wide variety of things that the ACIP has to consider. And what I'd like to do is, since I repeatedly brought up this mysterious entity called the ACIP, I'll take a few minutes and describe for you what it actually is. The Advisory Committee on Immunization Practices was first established in 1964, so that means it's celebrating its 50th anniversary this year, by the Surgeon General of the U.S. Public Health Service. And its function was to provide advice and guidance to the CDC Director and the Secretary of HHS, or Department of Health and Human Services, on matters that relate to vaccine-preventable diseases in the civilian population. By the way, the Department of Defense typically follow the ACIP guidelines as well. The ACIP is composed of 15 non-government voting members who are experts in infectious diseases, pediatrics, immunology, and other relevant fields, as well as one consumer representative. The members are screened repeatedly for conflicts of interest. The ACIP is supported by ex officio members who represent other government agencies and a number of liaison organizations that represent diverse professional interests. Currently, there are 13 working groups, each chaired by a voting member of the ACIP, that work behind the scenes to identify and discuss issues, gather supporting materials and evidence, and actually help develop positions for the ACIP to consider. ACIP meetings are open to the public and occur 3 times a year, and the next meeting will take place in October. ACIP recommendations, as voted upon by its voting members, actually become final when the CDC Director signs off on them, and the recommendations are published in the MMWR. These are the ACIP voting members as of February last year. Several members have rotated out of their 4-year appointments since then. Seated at the center is the outgoing ACIP chairman, Dr. Jonathan Tempe of the University of Wisconsin. To his left is Dr. Nancy Bennett of the University of Rochester, who will assume the chair responsibilities beginning with the meeting in October. Here is the list of other government offices and agencies represented in the ACIP. And here's a long list of professional organizations that liaise with the ACIP. As I mentioned, there are 13 ACIP work groups. 4 of these are permanent: adult immunization, child and adolescent immunization, general recommendations, and influenza vaccination. Other groups can be formed or disbanded based on need. Herpes zoster work group was recently formed, and pertussis work group is set to retire after the next meeting. As I mentioned, ACIP meetings are open to the public, and the public is invited to comment during the meetings. And there's a wealth of information, including topics on adult immunization on the ACIP webpage. So remember the question that I posed earlier, why are adult immunization rates so low? I'd like to get back to that slide. I mentioned that there are 4 big reasons as to why adult immunization rates are low. The first big reason was that adults are simply not aware that there are vaccines recommended for them. Yes, it's a problem, but it's also an opportunity because while adults are not aware, studies and market research have shown that most adult patients will accept vaccines if their healthcare provider recommends them. The second big reason is that the healthcare providers are too busy and have too many competing priorities. That is absolutely true. But healthcare providers also think that immunizations are important for their adult patients. So there is a will. So we have to find a way. The third big reason is that not all providers stock all vaccines recommended for adults. This is also true. But you have, of course, observed that the access points for adults to get vaccines have gone by leaps and bounds with pharmacists administering vaccines, plus the growth of alternative sites for vaccination, such as school clinics and occupational clinics, really increased the number of access points for adults. The fourth big reason is that adults frequently have multiple providers that make record keeping really very difficult. But there is an opportunity to overcome this obstacle. The answer lies in state vaccine registries. I'll discuss more on this later. In response to the low immunization rates for adults, the National Vaccine Program Office released the Adult Immunization Practice Standards last year. The standards state that all healthcare providers have a role in ensuring that their patients get current on vaccines. To do so, the standards call for healthcare providers to, number 1, assess immunization status of all patients at every clinical encounter. 2, strongly recommend that they get the vaccines they need. 3, either administer the vaccines they need or refer the patient to a provider who does. And 4, document the vaccines that have been administered in their state vaccine registries. Remember the discussion on in the previous slide that vaccine record keeping for adults is difficult. If vaccine record keeping is done in the state vaccine registry, the electronic health records can be automated to submit vaccination data to the state vaccine registry. And if providers have access to review the vaccination records of their patients through the registry, then providers can more easily assess immunization status of their patients. Presently, state health departments are racing to improve their vaccine registry capabilities, so I urge you to get in touch with your state immunization programs and link up with your state vaccine registries. Clearly, state vaccine registries can be very useful tools to assist the busy healthcare provider to his or her job better. State vaccine registries can increase accuracy of adult vaccination assessments, as I mentioned earlier, support patient reminder and recall intervention, and facilitate provider feedback. Unfortunately, at this point in time, only 8% of internists and 30% of family physicians were recently found to be using state vaccine registries. So there is work that we can be doing better. The good news is that state health departments are revving up to prepare state vaccine registries. This is a snapshot of the state status of state vaccine registries preparedness to work with adult immunization activities. In the CDC Immunization Information System Annual Report 2013, the percentage of adults in the United States participating in vaccine registries, that is, the percentage of adults who have at least one adult immunization record documented in the registry, is 32% overall. Some jurisdictions are doing really well. 10 health departments had adult participation rate of 50% or higher. 22 jurisdictions had participation rates of 25 to 49%, and 19 jurisdictions had rates that were under 25%. This figure shows the percentage of adults who are enrolled and participating in state vaccine registries. Those who are enrolled means that they have been accounted for in the registry as adults, either as having aged in from their pediatric records or as new entries. In 2014, 54% of the adults in the United States were enrolled in vaccine registries, really encouraging. And we see that 34% of adults have at least one adult immunization record documented in the registry in 2014, up from 32% in 2013. These numbers obviously need to come up, and the state health department as well as various folks at CDC are working hard to make this happen. I urge you to link up with your state vaccine registry to help the system and help do what the system is designed to do. Switching gears a little bit, a key strategy to improving adult immunization is having providers make a strong recommendation for their patients to get vaccines. An example of the impact of the provider recommendation is this data from a survey of pregnant women. But the provider recommendation is not just impactful for pregnant women. Research shows that the provider recommendation is a key factor in people getting vaccinated against the flu, as well as promoting other vaccines. In this example from a survey of pregnant women, we'll look at the bars going from right to left. Without a recommendation or offer for vaccination, the flu vaccine coverage rate was abysmal at 16% among pregnant women. The next bar to the left is that when the vaccine was recommended but not offered, the coverage rate was substantially higher at 46%. Next bar to the left. If the vaccine was recommended and offered, meaning the pregnant woman was recommended to receive the flu vaccination and was asked to roll up her sleeve so she can get the shot, the coverage rate was substantially higher at and having up to 70%. This example also demonstrates the importance of providers vaccinating at the time of the recommendation. And this vaccination pattern was found in all demographic and other subgroups, even among women who had a very negative attitude towards the influenza vaccination, again, demonstrating the importance of a provider recommendation. Research has shown that healthcare provider recommendation is a top factor in patients deciding to get vaccines. So, are providers actually making recommendations for adult immunizations? Looking at things from the patient's perspective, we see that that healthcare providers are doing better making these recommendations. The proportion of patients who have been recommended for vaccines increased significantly in 2014 compared to 2012 for the pneumococcal vaccine for adults 65 and older and for high-risk patients, and the doctor vaccine for 60 and older too. Recommendations for Tdap increased only slightly, but there was an increase. Adult immunization coverage rates do improve with provider recommendation, and providers are increasingly making recommendations to adult patients. Not surprisingly, a research group out of the University of Colorado led by Dr. Laura Hurley recently published a study in the Annals of Internal Medicine that found that systematic offering and recommendations from clinicians result in higher uptake of vaccines by adults. These and many more organizations support the implementation of the adult immunization practice standards, and I think it's not hard to see why. These are call to action items for the community to work towards improving adult immunization. Many of the items on the list are topics that we already discussed, like reducing barriers, improving access to adult immunizations, improving awareness of adult immunization recommendations, and ensuring healthcare providers' competencies. And of course, increasing the access and the use of vaccine registries by healthcare providers who care for adults. This call to action also dangles a carrot. A project promoting adult immunization can be a project of choice for physicians for maintenance of certification. And included on this slide is a URL for quality improvement projects targeting immunization. So there are many resources on the CDC website and the state health department's websites to help providers with implementation of the standards and a host of other materials to promote adult immunization. Is working on adult immunization a shot in the dark? Well, hardly. The need is there. The science and consumer research to help develop strategies are there. The vaccine registry infrastructure is there, or is getting there. Support at the health department immunization programs is there. So get in touch with your adult immunization coordinator at the health department. Plus, there is an immunization coalition in your community. So get linked. Become an adult immunization champion. Here are some adult immunization resources that are readily available so that you can get started if you haven't done so already. And that brings us to the end of the road. I appreciate your attention, and we do have a few minutes for me to take questions. Thank you, everyone.
The floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7 to ask the question.
Hi, Dr. Chung. This is Lena. I have a question for you. If someone has already had shingles, do they need to get the shingles vaccine? And if so, why is that?
Well, the doctor vaccine was licensed in 2006, and based on a large study called Shingles Prevention Study, and the recommendations that were based out of that remain. And the recommendation is that if a person 60 and older should get the shingles vaccine one time. So whether you had shingles or not in the past, it is recommended that persons 60 and older should get the vaccine, and and there's several reasons for that. I mentioned that that there are over 1 million cases of shingles occurring in the United States per year, and that and additionally there's a lifetime risk of herpes zoster per individual is approximately 30%, and that increases with age, as I mentioned also during the presentation. So, given the increase in lifetime risk for herpes zoster, it is recommended, regardless of your past history, because shingles can recur, and also regardless of whether you have received the chickenpox immunizations or not, that you get the single dose of shingles vaccine at age 60. Now, I should also mention that the shingles vaccine is only about 50% effective against herpes zoster, and about 2/3, 67% effective versus preventing post-herpetic neuralgia, the pain that Mr. Tolbert described earlier. So the question may be, well, geez, at 50% efficacy against the zoster, against shingles, and only 2/3, and it's only 2/3 effective in preventing post-herpetic neuralgia, the pain associated with zoster, even when everything clears. Should I get the vaccine? Well, my take on that is, given the lifestyle altering changes that shingles can bring about, with not only the infection but also post-herpetic neuralgia, I would say 50% prevention. I would take that chance anytime, and if I can prevent the pain 2/3 of the time, that's a pretty darn good odds for me. So I would absolutely get the vaccine, and I suspect Mr. Tolbert would agree.
Thank you, Dr. Kim. I have an additional question from Lisa, one of our participants. Do you have any suggestions on how to implement new pneumococcal vaccine requirements in the hospital setting?
That is an excellent question. In the hospital setting, I think that's the key there. As a quality improvement initiative, the hospitals have in the past and still is required to vaccinate their patients with pneumococcal vaccines. And it is complex, and given that the patients are hospitalized, there are issues related to the eligibility, if you will, or the qualifications for PCV13 and PPSV23, and needing to deal with all the permutations of the types of vaccines, intervals, frequencies, and age and health conditions and occupation, etc. of the patients. So the two slides that I showed earlier, one a table that looked like a menu for pneumococcal vaccination delivery based on patient description, and also the algorithm, the flow chart for pneumococcal vaccination. I think those two slides will be of assistance to you, and for me to go through the different permutations and through this discussion, it would take way too much time. And so we did attempt to simplify the process, and fortunately the ACIT is continuing to look at ways to improve the pneumococcal vaccination recommendation. So I don't have a simple answer for you, but there are resources available out there to try to make things as simple as possible.
And we are including your presentation on our online community, Dr. Kim, so they can refer to that slide there.
Thank you so much for doing that.
And then one last question from a participant. They had read about a new shingles vaccine and wanted to know if they should wait for the new shingles vaccine or to go ahead and get vaccinated now with the vaccine that is available.
Another wonderful question. Well, the new shingles vaccine is the herpes zoster adjuvanted subunit vaccine. It appears to be really promising, and it's currently in phase 3 clinical trials. And it's attenuated because I should say, it doesn't require special handling and refrigeration that the current vaccine requires. It's a vaccine antigen glycoprotein, and it's coupled with an adjuvant to help deliver the immunogenicity. So there's a lot of promise there, and when it's approved, it will be the vaccine of choice for zoster vaccination. As to whether we should wait for that vaccine to come out and actually be reviewed by ACIP for recommendation, or should we use the existing vaccine now if we or the patient is 60 years of age or older? I think other vaccines come out all the time. One vaccine that I mentioned earlier was HPV-9 compared to previous iteration, where it would have some additional coverage against other serotypes of HPV. Is it worth the wait? Now, if I had to make a recommendation to my parents today, or if I had looking at the possibility of getting the zoster vaccine today, as opposed to waiting for the promising new vaccine, given the consequences of not being vaccinated and being infected with, of having to deal with herpes zoster and its painful consequences. This is my personal opinion that I would take the shot now, and I would tell my parents to get the shot now.
Thank you, Dr. Kim. And then one last question. It seems to be a shingles day. If a patient has had the shingles, should they receive the shingles vaccine earlier than 60 years old?
The answer is complex, and it's probably there is no recommendation for persons receiving the shingles vaccine under the age of 60, because studies have been done the study that I mentioned and subsequent studies were based on the population being 60 and older. We do know that the herpes zoster burden increases with age, and that the duration of protection is uncertain. But we do think that protection actually wanes over time, and so there is no recommendation of a booster after age 60, although that issue is being looked at by the ACIP. So if you, like many other people living in the U.S., end up with herpes zoster, and the annual rate, incidence rate, is approximately four new cases per 100,000 per year. So it is significant. Then should you get the vaccine earlier than age 60? Well, two things. One, insurance won't cover it, and it's not a cheap vaccine. So I suppose if you can find a provider who will administer the vaccine under age 60, given risks, then you can get the vaccine because the FDA licensure. Remember what I mentioned about about off-label use and the voucher for persons. Faster vaccine for persons 60 and older. That's actually a little shift from the FDA licensure that said persons under 50, persons 50 and older can get the vaccine. So if you're 55 and you don't want to take the risk of getting dealing with post-traumatic neuralgia, then it is safe and effective. Even at under age 60, but it won't be covered. So that's an individual decision that has to be made with the patient along with the physician consultation. But as far as ACIP recommendations are concerned, there is no recommendation for persons under age 60 to receive the zoster vaccine, even if they had zoster in the past.
Okay, thank you very much, Dr. Kim, for answering those questions. And we will put the questions and answers on the online community so participants can refer to Dr. Kim's answers there. At this time, we've run out of time. So once again, I want to thank Dr. Kim and Bernard Talbert for assisting us with our presentation on immunization improvement. So we want to thank you both for attending, and we want to thank our participants as well. Please fill out the evaluation form that you will be getting after the presentation so that we can improve how we do our presentations. Thank you very much.
This concludes today's teleconference. You may now disconnect.